Hi, I'm Ros Herbert. I'm a GP who works with QMAC. And we recorded this PowerPoint to give you some ideas about how to supervise students doing phone and video consultations in your practices. The students are coming back to the practices very soon, and so we wanted to think about this together as it's a new skill, really, something that we all haven't done before. So the students were last with us beginning of March, end of February, and they come back into our practices really to a new world of primary care. We're wearing PPE, most of our consultations are remote, so it's very different from when they first left us and when we were teaching them before. We have all had to adapt as a result of the pandemic. And I think as GPs, we've done this amazingly well. We have all found this, I think, a steep learning curve. I've particularly found it a steep learning curve because I wasn't doing many telephone consultations before. Maybe you were, but we weren't necessarily supervising students doing this anyway. I think for all of us, opening again is slow. We all work in very different contexts, but we now need to make this new world into a learning environment. And that's what we wanted to discuss and for you to think about as you watch this PowerPoint, how to make your surgery now into a learning environment. So the good thing is our students are now classified as key workers. We need junior doctors to qualify next year, and we need them to have had experience. So you're very, very justified in having them with you, in them travelling to your surgery, and the fact that students are so adaptable, more adaptable than us, is very much in our favour. So today, I just wanted us to think about good practice in terms of phone and video consultations, to think about some of the practicalities of supervising the students with these new mediums. And then we've got some video clips that we've made, and then we can really think about the summary of all the points together. So I found it very useful to watch some videos and training modules at the beginning of this pandemic about how to do telephone consultations. Maybe you did too. So I'm going to run through some of the best practice. Introduce yourself and anyone else on the call. Make sure you take and record consent and explain what will happen if you get cut off at the outset. This happens to me a lot in the practice. I don't know about you, but the patients are relieved when they know that I'll just call them straight back. Consent is key, especially if you're not talking to the patient. Where I work, we have a lot of language issues, so often I am using somebody else to translate. Now, an idea I think I found was really interesting was the fact that in telephone consultations you don't have a golden minute, you have a golden 30 seconds, because silence is even more powerful on the phone. So if you can pause and leave 30-second break, the patients will very often tell you what's wrong very quickly and come to the point with exactly what they want and need. Just as with face-to-face, it's very good to establish if they have a list, and also it's good to establish as quickly as possible if you need to move to another medium, such as video or face-to-face. In terms of communication skills, audible cues are still incredibly important because you don't have those physical cues that you can see. Patients can't see if we're nodding our head and signs like that to show we're listening. So I'm sure you do the same as me, and you find that you're saying okay a lot. So patients can hear that you're listening. They don't think you're then signing all prescriptions or shopping on Amazon or all the other things that you might be doing. Much the same as with face-to-face, open questions are incredibly important. And you still need to signpost to your patients, especially if you're interrupting. I think I found it helpful to think that it's fine to interrupt, and we need to interrupt to clarify a point and to keep the consultation on track, but we just need to signpost why we're doing that. Very helpful again, I think, is to be very clear and direct with your questions. All the normal non-verbal communication is now lost, so clarity is incredibly important. At the end of the call, just as you would face-to-face, summarise the key points and check that the patient has understood. You may need to explain something again or explain what will happen next again. Explicitly say goodbye before ringing off and document as you normally would. Challenges, as I said, can be with those who are non-English speaking. So it might be that you have advocates in your surgery you use. You might still be using language line. Some practices use receptionists to translate. Some will be using family members who are with the patient at home. But again, it's about recording consent. Now, this is where I think it gets interesting. You may be doing this with GP trainees, with registrars already, but with students it is a new skill that we're all going to learn together. So the students will not have done a huge amount of telephone consulting, so they may need to observe you to start with. You could do this by putting the patient on speakerphone and then just explicitly consenting the patient, saying the student is with you in the room listening in. You could then get the student to start the consultation and again explain to the student that you are listening in while they are on speakerphone. You do need to take consent and explain who is in the room and that nobody else can hear them and that it is all confidential. Then you might use some other methods. It might be that students can initially begin the consultation in another room and then say they will consult with you and then ring the patient back. It might be that you want to finish off the consultation by both ringing them back on speakerphone. Another way to do it is to use an iPhone and add another caller, and that's quite a simple thing to do if you've got an iPhone and the student has an iPhone. This is Dr. Aisha News, and she is using Microsoft Teams. So her trainee is shielding at home. He is doing a telephone consultation from his garage, which he's set up, as a consulting room, and she is watching him using Microsoft Teams. Teams is the NHS approved platform rather than Zoom, because it's felt to be more confidential. And I think most of us are using Teams for different meetings in our surgeries. So she can listen in to her trainee consulting the patient, and then on Teams she can just type in the chat, oh, this patient sounds like he needs to come in, ask him to come in to see me at the surgery, and then they can arrange a time. You can use the chat function on Teams very effectively to supervise your student if they are not in the same room as you. Again, very important is to take good consent for this, that you are supervising and that the trainee is there as well. I think one thing that everyone's quite concerned about as well is the remote consulter in a safe, confidential environment. So this trainee is in his garage, his family aren't there, there's nobody listening, so it's a confidential environment, but we just need to make sure that that is always the case. The students who come back to our surgeries aren't going to be doing remote consulting like this. They might just be in another room within the practice. But again, we need to make sure that they're not interrupted. One point I think is really important is to exaggerate the conscious role modelling. So explain why you are doing things, why you're beginning with maybe a bit of chat about how they are, what they're doing, are they working, just to put the patient at ease. Why you interrupted at that point, why you decided to ask the patient to come in, what was the risk level that made you do that. So sometimes the students can observe some of these things physically, but if it is just audible, they need to really know why you're doing things so that they can learn some of these skills as well. Then in terms of video consulting, I think we've all had to get used to the tech. So before you're video consulting, always check your tech. Most of us seem to be using Accurix in our surgery. We have to arrange a very specific time with our patients because they need to be in front of a screen or have their iPhone ready with Wi-Fi so they can talk to us via video consult. Think about what limited physical examination is possible. It might be that you could demo to the patient how to take their pulse and then they could do that. It might be that there could be some sort of joint examination that was possible. I saw someone with a wing scapula the other day that I could see very clearly on video consult. The general consensus that is photos are better for rashes. I'm sure you found that as well, and that you need the patient to email you in a photo before the consultation. And then again, as always, call people in if necessary. Now, in terms of supervising, the students will need to observe initially. Then you can all be in the same room as they can begin the video consultation. As I said, you can do three-way via Accurix or Teams, but again, make sure of confidentiality and consent. Or it could be that they begin initially, they break, and then you come in at the end, which is kind of our usual model in face-to-face consulting with the students. So we have some demos that I'd like you to watch. If you watch clip 1 and then come back to the PowerPoint. So you can see in this clip that Tocton does a normal sort of consultation, but it's just done by video. Now I am watching this one remotely and taking in all the information, and then I deliberately create a break so that then I can debrief Tocton. So this again might be something that you can do in telephone or video consultations, but it's just a normal history that the student can begin to take, and they will often follow their same pattern that they've been taught all along. So then if you watch clip 2, this is us doing the end together, which I think you will often have to do in the surgery because you need to see the patient and confirm that this is the plan together. So if you watch clip 2. So in clip 2, Tocton actually does more safety netting than me, which I think is great. So again, stress that you need to safety net and that the students really need to safety net and what the plan is afterwards. But you can see how this works quite well, and then we've got a nice sort of joined up consultation. These are some of the references that I found really helpful, and most of these courses are free. I think this is a new skill in terms of teaching that we're all going to learn and get used to. So I think it would be great to have some of your feedback. Please email us at QMEC Teachers with other ideas or other resources that you found useful. And bear in mind that this is something that you and the students can learn together, and it's going to be a skill that the students need for some time in the future. So thank you.